So nutritional management of critically ill patients with reduced kidney function. Since morning, we have been listening to so many nice perspectives, and I would give intensivist perspective about what should we do basically. So my flow of the talk would include just a brief about pathophysiology of renal disease. We all know evaluation of nutrition in renal diseases, CKD assessment of biochemical parameters. Then I would present two or three cases just to make the ball rolling. And then along with the cases, we should discuss about nutrition prescription in focus, nutrition requirements in AKI with or without renal replacement therapies, micronutrients and loss and replacement, and then route and type of nutrition, and definitely revisit the nutritional cases at the end of the talk so that we know what we have learned. So as we all know, renal damage and subsequent loss of renal functions profoundly affect the metabolism, nutritional requirements, as well as nutritional status of the patient. We see a lot of patients coming to OPD as well as indoor, where they are nutritionally very much depleted when they already have underlying kidney disease. Urine output decreases, resulting in accumulation of fluid and electrolytes in the blood. And few patients who are coming to you would be definitely edematous all over, and few would be excessively cachectic. That is what I can tell you. So retention of nitrogenous waste leads to uremia, and uremia can lead to uremic gastropathy and a lot of complications, and uremic gastritis, and the appetite goes down tremendously when it happens to the patient. Also, acidosis occurs because kidneys cannot excrete excess acid produced through normal metabolic process, and renal damage can result due to kidney disorders such as glomerulonephritis, polycystic kidney disease, obstructive kidney, and congenital kidney malformation. So these are the stages I would not discuss. Whenever you are evaluating a patient of nutrition in CKD, so you definitely refer to a registered dietitian who need to assess the patient before we start off the nutritional assessment as well as management of the patient. Patient history, including medical, social, personal history, history of medication, supplements that are ongoing is very important, as well as to analyze the biochemical data and relevant laboratory values. Anthropometric measurements goes without saying, monitoring height, weight, body mass index, waist circumference, and weight change ratio. What are the weights in the previous dialysis session as well as what is the current ongoing weight? Nutritional history, including food intake, what are the habits, physical activity, exercise, food availability with the patient is also important. You might prescribe many things, but is it available with him? Can he make use of it? Psychosocial as well, economic issues impacting nutrition therapies again needs to be discussed. Physical examination findings are also important. So the formulation of renal diet is relatively complex compared to planning of other modified diets that we have seen in clinical practice. Diet components must be regulated as calorie content, protein, sodium, potassium, water, which is very, very important. Particularly potassium, magnesium, phosphorus, all these things are very important when dealing with the chronic kidney dissipation, and also calcium and phosphorus as there is renal osteodystrophy ongoing. So nutritional requirements in an ICU, if you see, the caloric requirements definitely would be indirect calorimetry would be a gold standard, but it's not available and not routinely prescribed or done. Beer's equation is what can help us in knowing the energy equivalent basically, and then it is the equation that has several values you need to put and then get your energy efficient. So proteins by the nitrogen, protein by the nitrogen output equal to input. We know that we need to maintain a positive nitrogen balance in patients basically. And nitrogen balance is equal to total protein intake in grams upon 6.25 minus urinary nitrogen plus 4 grams. It is not valid in the presence of burns, fistula, wounds with high protein output as well as for the renal failure. So we need to correct for these. And nitrogen balance in AKI, urinary sodium grams per day, urinary urine nitrogen plus change in urea nitrogen pool. And this is the formula that gives you estimating catabolism, a possible tool for nutrition monitoring of patients with acute kidney. So nitrogen balance is definitely an essence whenever monitoring as well as prescribing anything. We know that the total nitrogen loss without dialysis and dialysis. So non-uric nitrogen, that is body weight into 0.031 or 2 gram. Plus there are fecal losses, fecal volume into this thing you can, as an average, you can take 2 grams. Plus during dialysis, there is a dialysate losses, and N-dialysate per gram per liter into dialysate total volume is what we can add to that. So total nitrogen assessment will be urinary nitrogen and plus fecal losses plus insensible losses. So calculation of catabolism degree, NB being the nitrogen balance, TNA being the total nitrogen appearance, and UNA being the urea nitrogen appearance. So these are the formulas that we need to apply and then get our balance. So to start off with, I will discuss this case of 18-year-old boy who was around 55 kg, previously healthy. Day 1 to 2, he had dengue with encephalopathy with oral bleed. So that's why he was kept NBM. Later on, he becomes bad, goes on ventilator. There is ARDS, gets intubated, ventilated, again remains NBM. Now there is a shock. So So that's how vasopressors are on the table. Lactates being 14 started on CRRT within time. As far as sugars management was concerned, 25% dextrose at 20 ml per hour, so roughly around 500 kilocalories. And day 4, he becomes prone on ventilator, again remains NBM. Day 5, shock is better, but NORAD is down to 0.1 microgram per kg per minute. Lactates, they are coming down on CRRT. And there is negative balance achieved by CRRT. Patient made supine, still paralysis is stopped. And now serum ferritin of 1 lakh and LDH more than 10,000. Started on feeds 20 ml per hour with MVA opinion IV 41 since day 1. So day 6 to 10, patient showed improvement, ferritin down, platelets up, tracheostomies for weaning off from the ventilator. Feed started 80 cc per hour by day 8, calories 1800, protein 60 grams per day, and daily sled ongoing. Fluid balance 1.5 liters positive. Do you all think is the nutrition provided adequate in last 10 days of ICU stay? We'll discuss later on. Case 2, 66-year-old, 75 kg with diabetes, hypertension, CKD underlying. There is cervical myelopathy with restricted mobility since 6 months. Admitted outside for 14 days prior to transfer. Has a diabetic foot leading to a source for sepsis. Transport intubated, ventilated, HD catheter in dialyzed once in previous hospital for AKI with creat being 9.9 and acidotic. Day 1 to 7 is a course, septicemia, shock, encephalopathic again, edematous, HD catheter, ET secretions, wound all over they grew, Acinetobacter baumannii as is expected in such group of patients. Daily sled ongoing, albumin say 1.69 on admission. I would say albumin is a acute phase reactant. So definitely it is showing that part. Started on feeds NG 20, 40, 60, gradually increase on day 4 when the shock has reversed. Cholesterol, digoxin, antibiotic ongoing, tracheostomies again, this patient also. Insulin infusion to keep the HGTs between 110 to 150 and calories around 2000 kilocalories per day, protein 80 gram, MV and opinion daily 1 ampule. Day 8, positive by 9 liters discharge. Again, is the nutrition enough? Can we make any changes in the content is what I want to discuss later on. 34-year-old is my third case with 44 kg post-pancreatic necrosectomy, BMI less than 20, started on TPN, 60 cc per hour with calories of 1400 and amino acids of 50 grams. Essential elements IV ongoing, MVA opineuron, multiple drains around 5 with drain output of 1 liters daily. Day 4 has to be explored for suspected bowel perforation and again post-op developed septicemia, AKI, oliguric urine output being 25 to 30 cc per hour. Patient is in shock with creat of 2.5 and from 0.5 which was the pre-op creatinine. Has a massive blood loss intra post-op due to DIC. Stabilized on day 6, again TPN restarted at the same rate as patient went on sled on fluid could be adjusted. So critically ill patients with AKI and nutrition, AKI affects the fluid, electrolyte and acid-base balance as we all know. Effect on protein, carbohydrate and lipid metabolism is a combined effect of AKI and the underlying illness. Macronutrients and micronutrients intake is also altered by RRT and type of RRT that is chosen as losses on RRT have to be factored in whenever you are prescribing or trying to adjust for nutrition of this patient. And ideally, every patient's energy requirement should be measured by indirect calorimetry, as I was telling in the beginning. But indirect calorimetry is not easily available as well as easily or widely available. And trials have not shown a distinctive advantages of indirect calorimetry. Nutrition guidelines still prescribes 25 to 30 kilocalories per kg for critically ill patients with warning to be not overfed. And we know that what can happen if you enter into an overfeeding or refeeding syndrome. So that's why we need to be very careful while refeeding a patient who's NBM since last 7 to 8 days. And so we need to start slow and build up gradually. Protein requirement varies from 0.8 to 1.5 grams per kg per day. Carbohydrates and lipids should provide around 75 to 80% of the total calories so that we can adjust for the nitrogen balance of the patient. Enteral route is preferred over parenteral. Definitely, whenever gut is ready, use the gut rather than parenteral. We know what can happen with parenteral nutrition. When there is no choice, we have to choose, but then it definitely adds a risk to a patient who is already septic. Time to initiate parenteral depends on the underlying nutrient status, and hemodynamic stability is a very, very important factor. Whenever the patient is on 2 vasopressors on a higher dose, you cannot feed the patient. We need to wait for him to stabilize and then only we can start. Micronutrients need attention and needs depend on use of renal replacement therapy. As far as micronutrients, we all know electrolytes, vitamins, minerals, micronutrients requirements is poorly studied in AKI. Further, the effect of RRT on removal of mainly protein-bound trace elements are far from clearly defined. However, data shows that selenium, copper, zinc, and can be removed by convective as well as diffusive RRT. And levels of vitamin C, folic acid, thiamine are reduced due to losses on the circuit. And I think all these patients need supplement of these whenever they are on RRT. Thiamine loss is 1.5 times the daily provision. That is what all of us needs to know. Phosphorus and magnesium, definitely there is depletion likely on CRRT, need to be monitored and replaced whenever appropriate. Phosphorus containing fluids are now being manufactured for CRRT, wherein this phosphorus loss and other things can be managed. Glutamine, it's a conditional amino acid essential for cells with rapid turnover like enterocytes and cells in immune system. Definitely forms a part of the immune nutrition that needs to be considered. And glutamine losses is there on the RRT. In patients undergoing CRRT SLED, large losses of glutamine may occur, and here supplementing a dose of 0.2 grams per kg per day is what is recommended. This is still not being tested adequately in bigger trials so that we can have that experience and start using in our clinical practice. In general, glutamine supplementation has been proven to be of no benefit in certain trials, as well as there's a confusion in this. So continuous renal replacement therapy, amino acid, trace metal, and folate clearance in critically ill children is what was suggested in this pediatric study that was done by Mikhail Zapatili. And they reported the first evaluation of the effect of CVVHD clearance of multiple nutrients in critically ill children. And they found that significant amino acid, folate, and some trace metal loss occurs by CVHD, which may impact on nutrition position of the patient. Abnormal protein metabolism in acute kidney injury is contributed by critical illness, and altered renal amino acid metabolism is manifested as protein malnutrition and negative nitrogen balance. We found that CVVHD amino acid losses equated to 10% of total amino acid intake, and this mammoth loss happens, and 70 to 20% of amino acids are provided by parental nutrition, even if you are supplementing. So you are supplementing less and there are losses ongoing. So nitrogen balance was negative, and despite protein provision of approximately 2 grams per kg per day, suggested that CVVHD losses contributed to worsening negative nitrogen balance, and that is what was reported in this paper. But not all is lost on RRT. The energy excess provided by citrate, lactate, and glucose in RRT solutions should be factored in patient cumulative energy balance to avoid overfeeding and hyperglycemia, because that also contributes. It's going on with the patients in the form of the citrate and lactate and glucose in RRT solutions. And recommended range of sugar is 110 to 150 milligrams per deciliter as per KID2 guidelines. As far as fluid balance is concerned, it's definitely a very, very tricky topic in patients with CKD, how much to give and how much not to give. Fluid balance is always crucial aspect of managing patients. Very often they are in overload before coming to you because the renal functions are not appropriate, and there is definitely these patients when becomes hypovolemic, they get a tremendous third space loss and they become swollen from inside, even if they are intravascular. So there is relative intravascular depletion and hypovolemia in this patient, even if they are looking overloaded from upfront. So the challenge remains to provide nutrition in smallest possible volume. To control the volume as well as nutrition is definitely a challenge, and I face this problem in and out in my clinical practice. And we had a discussion with Zamrud daily about how much volume and how much she can provide from her end. That becomes a challenge. RRT sometimes is indicated to ease administration of adequate nutrition and avoid large positive balances, which is associated with higher mortality. So previously the concept was the bigger is better, basically. So people used to give more tidal volume. There were more fluid given to the patients and more calories were given. And now the concept is the lesser is the better. So low tidal volume and lesser volume of the fluid to be given to the patient. And that is how lower calories and other things are coming, and that is helping the patient. So time and route of feeding is definitely an important part. Early enteral nutrition is what is recommended as a route as per guidelines from ASPEN, ISPEN, or Canadian. You take any guideline. Early TPN within 48 hours in case of enteral route cannot be established, is only on ASPEN recommendation. Other guidelines, they do not recommend that. ASPEN recommends it on day 8 in case of enteral. It cannot be established till now. This is not true for previously malnourished patients where early TPN is recommended, where you know that enteral plus parenteral you need to combine to achieve a goal of nutrition. So this was about management and nutrition in AKI and with renal replacement therapy. So you know that acute critical illness, stress, immobilization leads to anorexia, starvation. There is delayed start of nutrition therapy, as we discussed in our cases. There is insufficient nutrient intake from the patient side because of loss of appetite and inability to consume things. Low protein intake to delay RRT, estimation of nutritional needs, and acute kidney injury, metabolic acidosis. All these contribute to catabolism, lean body mass wasting, and there is protein energy wasting in the patients. And all these factors leads to inadequate delivery of proteins and calories, leads to protein energy depth, and again the same. And this protein energy wasting leads to increased mortality, increased morbidity, increased length of stay, and increased cost to the patient. So this is all we need to know, and we need to correct as soon as guidelines. And then these are the guidelines, ISPEN, ASPEN, KID2, and these are the recommendations by Grossley, and the route definitely enteral. Everybody will will prefer, but then few patients need to combine the parenteral placental where you know that the goals are not met. Coming back to our cases which we discussed initially, previously healthy, he was not malnourished, acute illness, PN can wait for 5 to 7 days, 55 kg, calorie requirement 1375 to 1650 kilocalories per day. Protein requirement in this patient was 82 grams, so micronutrients added were thiamine, folic acid, vitamin C, glutamine essential elements were. So good fluid balance achieved as CRRT in initial phase. For case 2, he was an elderly with malnourished, already hospitalized for 14 days, septic shock and MODS. PN should have been initiated on day 1. Micronutrients and essential elements definitely require supplementation, and this was the prescription for him. 17 kg, so 1875 to 2250 calories. Proteins of 100 grams would be desired and targeted. Fluid balance determined to outcome, and most avoid hyperglycemia because he was already having source as diabetic food. So 4 weeks pancreatitis was the case 3rd, basically, which we discussed initially. Started on TPN and surgery on admission. So calorie, protein adequate as per guidelines. Glutamine, again, we are not sure. This is the ideal case for indirect calorimetry and nitrogen balance calculation. I thank you all for your kind listening. I'm open to questions if any from the audience.